Good evening, everyone, and welcome. Thank you for dropping by for this, the inaugural forum event of the newly revamped Bloomsbury Patient Network. It is our very great pleasure to be able to offer this very timely, particularly today, exactly 1 year after the start of lockdown proceedings, this timely forum on living well with HIV in COVID times. Before we get started, I just want to go through a couple of housekeeping lists to make sure that everyone's aware of exactly what's going on. This is obviously an open forum, so anybody with the link has been able to access this, but we've done absolutely everything we can to make sure that confidentiality is observed and anonymity and disclosure risk is minimized and things like that. So be aware that there are many different types of people here. There will be people who are patients at Bloomsbury Clinic. There will be non-patients as well. Some people living with HIV, some people not. And attending this forum is in no way any indication of any kind of declaration of HIV status. It's going to be a very informal sort of chat session. We have our guest, Dr. Laura Waters, who's going to be popping on screen in a second. And what we really want to do is, this is your forum. The Bloomsbury Patient Network is about hearing the voices of the essentially the patients of the Bloomsbury Network and trying to meet their needs as much as we possibly can. So we're really keen on getting as much feedback as possible. We've disabled all the chat functions in here for confidentiality reasons, but the Q&A function is operating. And if you have any questions, if you've got anything you've already thought of that you would like to know the answers to, do pop it in the Q&A. There is a little button just before you press send that says post anonymously or send anonymously. And if you are worried about your personal data being seen even by us, then you can click that button, and even we won't know who's asked the question. The attendee group won't see any personal details of anyone apart from us, the panelists. I should start by introducing myself, really, shouldn't I? My name is Nathan Gaich, and I've been a patient at Bloomsbury Clinic since getting my HIV diagnosis in June 2017, and I've been a member of the Bloomsbury Patient Network Steering Committee, apologise for the sirens, ever since. And we've had a bit of upheaval and restructuring going on, which is why you haven't heard from us for a while, but we are back, and we are really keen to start providing much more diverse types of events, not just when we can, some social events in person, let's hope, but also these kind of online forums as well. So this is our tester to see how well it works and how well it suits your needs. We are recording this session already, so if you ask a question which in any way divulges any of your personal information, please be aware of that. This is going to be going up on YouTube and as an archive on our website, because that way we can reach as many people as possible in the future. If you have any questions related to tonight's topic, I've already talked about that. So yeah, the Q&A, get going on that as soon as you can if you've got any questions there. Or, as I said, if anything comes up as a result of the discussion that triggers something else that you want to ask, don't be shy, please do let us know. And at the end of the session, just before you all leave, I'm going to activate a little poll, which just got 5 very short questions. They're all multiple choice things, so that we can get some feedback from you on how well or not you think this has gone. That is really crucial to us, because we really want to boost the levels of engagement we get with the people that we are here to provide help and service for. Otherwise, what's the point of being here? So please, if you don't mind, hang around just for 2 seconds before you leave, fill in your questions to the poll, click the send button, and then you'll be free to go. Thank you very much for that. The most important thing about this whole event is not these housekeeping messages, it is welcoming to our screens our guest. She is the head clinician here at the Bloomsbury Clinic, not here, this is my house, but she's not only that, she's also the chair of BHIVA, and also, are you the chair of BASH as well, Laura? Is that
No, I did consider doing both at the same time, because I'm that confident in my own abilities, but no, that would be the first. I might do that next.
Yeah. So welcome Laura, thank you so much for being part of this event tonight. I think this is the perfect way to kick things off again with the new improved Bloomsbury Patient Network. It is so important and so in the forefront of everyone's mind. We're saturated with information, but also with misinformation and with half information. So hopefully you'll be able to put some of that right for us tonight.
I hope so. I hope so. So, well, hello everybody. So, as Nathan has said, I am the HIV lead at the Mortimer Market Centre. Actually, we've got a service in Surrey as well, although they manage perfectly well with just some distant input from me. And I'm also chair of BHIVA, the British HIV Association. So we want to make this as chatty and interactive as possible. So I deliberately haven't made any slides. Anyone who's seen me do a network event before knows I do love a PowerPoint slide. So I feel slightly naked in that regard. But I thought I'd just talk through some topics and then we can deal with questions as we go through. So I think that a couple of questions have come through. I'm going to address them actually when we reach the vaccine part of my sort of list of things I'm going to cover. So I will come back to those specific questions about vaccines. But of course, you know, COVID has completely changed all of our lives in one way or another. And it's been a hugely challenging time for everybody. And I think we'll be counting and measuring the impacts of this for years and decades to come. Life isn't going to be the same. I think some things will be better, but clearly there's been an awful lot of trauma. There's a hell of a lot we still don't know and understand. And there'll be questions tonight that I probably can't answer. Well, certainly there'll be questions that I can't answer, but I think acknowledging what we don't know sometimes is as important as discussing what we do know. So what I wanted to talk about first was the interplay between COVID and HIV. So when COVID first emerged, of course, it was towards the end of 2019, but it was really early 2020 that we realized it was going to be a big issue. And one of the questions for everybody at that time was, who were the people who were going to be most at risk of getting COVID, but more importantly, most at risk of getting sick or dying from complications of COVID. And one of the groups that we always think about is people with suppressed immune systems. So immune systems that aren't working 100% as well as they should be. And of course, within that category sits HIV. And although, of course, treatment has transformed the outlook for HIV, there are still many people with HIV, either because they're undiagnosed or for whatever reason, they're not in care and not taking treatment, who do have damaged immune systems. But there's also the fact that we still don't fully understand, even when you've got HIV that's well controlled on drugs, your immune system is good enough for most things, but it's not 100% perfect. There's still a little element of damage to the immune system, and understanding whether that's important or not is a question that's a focus of a lot of research that's ongoing. So from the beginning, we took a cautious approach. Now, was there enough evidence to say everyone with HIV must stay at home and shield? No, there wasn't. But was it reasonable to think that people with a lower CD4 count, or with a detectable virus, or with a recent serious HIV-related illness might be at higher risk? We thought actually that seemed sensible. And so that was the advice that we gave. Now, since then, we've learned some more, still not enough to answer the questions fully, but what's emerged since then is people with HIV are at a higher risk of dying of COVID. If you look at the various studies and you look at the risk of dying from COVID, people with HIV are at a slightly higher risk, but I need to put that into context. So people with HIV seem to be something around about double risk of dying of COVID. So if I say your risk is double, do you think, my goodness, that's a lot, that sounds awful? But if I said to you, your risk of dying is 1 in 10,000 and HIV makes it 1 in 5,000, the actual risk is still very low. And that's one of the things that's really difficult to understand, especially the way the media presents things sometimes. It's a difference between relative risk, which is me saying your risk is doubled, versus absolute risk. What is the actual risk of you getting sick? So the studies vary a bit. The other thing that's difficult is whether it's actually HIV. Because if you look across the population of people living with HIV, they're more likely to work in occupations where they might be exposed to COVID. They're more likely to live in areas. They're more likely to be of an ethnic group. and they're more likely to have other illnesses that affect whether you get sick from COVID or not. So is it HIV itself? Maybe a little bit, but is it also other factors that are more common in people with HIV? Probably as well. And it's really hard to pull that out because no single database, so we can look at GP records, we can look at HIV clinic records, we can look at death reports nationally. There's lots of places we can look, but none of them gives us the whole picture. So we have to try and piece the bits of jigsaw together. Now, one good thing, I think it's a good thing, I hope you do too, is that the Department of Health, having not considered HIV a priority condition at the beginning, have prioritised people with HIV for vaccination. So people with HIV, all people with HIV are considered at a higher enough risk to get the vaccine sooner than they would usually. And that puts people with HIV in the same category as diabetes and asthma and other conditions that are associated with a higher risk. Not the highest risk conditions like cancers, transplants, and the kind of conditions and drugs that really damage your immune system. They're in a higher category, but it means everyone with HIV is in priority group 6. And across the whole country, as far as I understand, people in priority group 6 are being offered vaccine now. In fact, some parts of the country have already reached priority group 9. So there's 9 groups, 1 highest risk, 9 lowest of the higher risk, and then everyone else. So those priority groups 1 to 9 cover about half the population, and then everyone else is going to be starting to get the vaccine very soon. So that's the main message there. I'm just going to have a quick look at if any questions have come in relevant to that.
Because I've already had my first jab. I had it exactly 2 weeks ago today. In fact, I was at the clinic today giving some blood for a research study program, particularly looking at exactly that process of what goes on in my blood post-COVID and post-vaccine, because I had COVID-19 a year ago. So if that is a symbol of hope to people who might be very, very frightened, I am HIV positive and I had COVID and I'm sitting here today, and I was quite poorly, but I'm absolutely fine. And I think that's something that not many people necessarily know somebody who's in their situation who has had it. So I hope that's useful.
Yeah. No, it's important. And actually, Joe, I'm just because vaccination's third on my list of things to talk about, all of the questions about vaccination. So actually, I'm going to go through each of these in turn. So the first question is, can we be referred to a vaccination centre via the clinic, not through the GP? The answer is yes, but not quite. So it was only about a week ago that NHS England gave us the permission to be able to refer directly to vaccine hubs. So we've been waiting for guidance from them. So before that, all of the vaccines have been offered either occupationally, so if you're an NHS worker, you may well have had the vaccine already, for example, or via GPs. And so this advice came out from NHS England saying, yep, you can go ahead and refer directly to a vaccine hub, full stop. No explanation as to how you do that. So luckily, not all, but luckily many HIV clinics are parts of organisations that are doing vaccinations anyway. So Central Northwest London, which is the trust that runs our service, are also operating vaccine hubs. So we will be able to refer you directly. We're just finalising the mechanisms now, but hopefully within the next couple of days, we would strongly encourage you to go via your GP if you can, because we're going to have limited capacity. But if you can't get one through your GP, you're not registered, you don't want to go via your GP, whatever reason, we'll be able to offer you a booking link enabling you to book directly into a vaccine hub. And the information they require is very limited. The only thing we're trying to tease out is the detail around NHS numbers, because generally the vaccine is linked to an NHS number. But that doesn't mean if, for example, your GP is not aware of your HIV status, that's not going to be included. It will be your name, your date of birth, and NHS number that gets linked, just so they know you've had the vaccine centrally. They won't have access.
It's a really important step forward, isn't it? Because there are so many people, for a variety of reasons, who haven't and aren't able to disclose their status to their GP. My GP actually gave me my diagnosis, so that took care of that one for me. But for so many people, their HIV care and their general health care are two completely separate things. So this is something really, really very useful.
No, absolutely, and I think it's something we're pushing for from the beginning. And I think, you know, it is stressful, but we know that everyone who wants a vaccine will get it eventually. Because the other issue has been for people who are registered with a GP but the GP is not aware of their HIV status, so they weren't put into that group 6 to get the vaccine earlier. Now that did raise some concern, but to be honest, with many areas reaching the lower risk groups already, everyone's going to get the vaccine. It just might mean you got it a month or 2 later, and we don't think that's particularly important in the grand scheme of things. It's kind of caught up with itself, as it were. So yes, we can refer you directly. What we'll be doing is updating our website. I don't know how many people access the clinic website, but that's where we put the updated information. As a sort of more general thing, we've just updated the information on the British HIV Association website, which explains in each of the countries of the British Isles, the geographical Britain, not the political one, then that explains how to get the vaccine outside of general practice if you need to. So the answer is yes, the mechanism will be clear over the next few days, I hope. So moving down, some have suggested that people with HIV have suboptimal responses to vaccines. For example, those that seek to protect against things like seasonal flu. Is there any current research into the efficacy of protection from COVID after 1 or 2 jabs? And are our vaccines, this is all from the same person, are our vaccines providing effective protection, and can this be checked? So really important questions. The answer is we don't know. And studies are going on now. So the issue has been that very early on, many of the vaccine studies excluded people with HIV. So, for example, in the US, the initial studies for the Pfizer and Moderna vaccines, and those are 2 that are being rolled out widely. We're not using Moderna quite yet in the UK, though that's imminent. So they didn't include people with HIV, and there was a lot of pushback. So the Infectious Diseases Society of America, big group of doctors, wrote to Pfizer and Moderna, the 2 companies, and said this is wrong. You shouldn't exclude people with HIV. And actually, there was a lot of community activism on the issue as well. So both those drug companies changed their minds and permitted people with HIV to enter the studies. So there is some data. We still don't know the detail yet. So for example, the Pfizer vaccine study. So at the moment in the UK, we're using Pfizer and Oxford or Astrazeneca vaccines. There is some data in people with HIV, but it's not really enough to analyse separately. Because the problem with these studies, if you've got a study in thousands of people, but only 200 of them have HIV, you can get a rough idea, but it's easy for the data to be inaccurate when the numbers of people with HIV aren't big enough. So what I can say is there's no evidence and there's no rationale for the vaccine being less safe in people with HIV. The only vaccines we worry about are live vaccines. So some vaccines are based on a live virus. Yellow fever is a good example. And if you have a low CD4 count, there's a risk that that can cause illness. None of them are live. So that safety issue is not a concern. And there's no reason any vaccine may have side effects. The benefits usually by far, 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 far outweigh the risk of any side effects, but there's no suggestion yet that people with HIV are at bigger risk of side effects. So the more important issue is, and that's what the rest of this question addresses, is are the vaccines less effective? So we know people with HIV, even when it's well controlled, so even if you're on treatment with an undetectable viral load and a good CD4 count, your response to vaccines may not be as strong as someone without HIV. So examples are the flu one's been mentioned, and also hepatitis B as an example, where if you're HIV negative, once you've had 4 or 5 doses and we've done a blood test to show you're responded, that's it. You never have to be vaccinated or tested again. If you have HIV, however, we know there's a risk you might lose that immunity. So we measure antibodies. Antibodies are the proteins that your body makes to fight infections. Vaccines work by stimulating antibodies, and people with HIV can lose that immunity, which is why we check hepatitis B immunity every few years if you're coming to the clinic and you've been vaccinated against Hep B. So it's possible, or some might argue likely, that the same will apply to COVID vaccination. So if you gave the vaccine to someone without HIV, their antibody response would be bigger than if you gave the vaccine to someone with HIV. However, that doesn't mean it's not effective. So the problem at the moment is, one, we don't know about people with HIV's antibody response. But also we don't know, is the antibody response, if I was to measure the amount of antibodies that you had after a vaccination, is that what matches with the effectiveness? So does somebody with higher antibodies because of a vaccine, are they more protected from getting sick than someone with lower levels? Because you might have, this is what we know about flu, for example, you might have lower levels of the antibody, and hepatitis B is the same, but you've still got enough. You've still got enough to be protective, and we just don't understand. So work is ongoing. And actually, plea to everyone, if you haven't had a COVID vaccine yet, and you're willing to give blood before and after your vaccine, let us know, because we're doing a study at Mortimer Market. One of my colleagues, Dimitra, Peppa, who does very clever things with antibodies and immune system levels and stuff, she's doing a study to answer that exact question, measuring antibodies before a vaccine and after in people with and without HIV. And actually, it's Dimitra's work that's shown us that people who've had COVID, there's already some signs that people with HIV might produce lower antibodies to the actual infection. So if you had COVID, your antibody levels might be slightly lower. So the data is not complete at the moment, and we don't know, but it's likely that even lower responses are still protective. And the key thing is, as long as the vaccines are stopping you getting really sick and dying, that's the most important thing. And it would seem, even where vaccines aren't performing as well, so there's some data from South Africa where one of the vaccines doesn't seem to work quite as well in people with HIV, it still seems to work well against severe illness. Same with some of the variants. They're not as protective against some of the variants, but they're still stopping people getting sick and dying. So that's the main aim of these vaccines, is to stop people going into hospital, and
And
there
I
they
think
seem
that's
to
one
be
of the
working.
most important things that people misunderstand. A lot of people are saying, well, I don't want to have the Oxford one over the Pfizer one because it's a lower percentage, because they think that the vaccines are there to stop people from catching
Yeah.
COVID. But it isn't about that. It's
No.
about preventing the more severe responses.
Absolutely. And then they do prevent people getting COVID, but the main thing is to stop people getting sick and dying. And there they all seem to do the job. And so the last part of that question, can this level of protection be checked? Yes, it can be checked, but at the moment only in research trials. It may well be in a year's time, everybody will be having regular antibody checks, a bit like with Hep B. Or it may be that we don't bother checking antibodies and everyone just gets a slightly different version of the COVID vaccine every year, like flu. We just don't know yet how that's going to pan out. But ultimately, none of this should stop anyone getting a vaccine. Get the vaccine still, and let's worry about whether you might need an extra booster or one type over another. But at the moment, there's no evidence that one type works better than another of the types we've got available here in the UK.
There's so many questions about vaccine hesitancy and things like that. I think there's a lot of what I would consider to be damaging misinformation, particularly perpetuated on social media rather than even the main media, which are quite sensationalist. They like to latch on to the tiniest little thing because we live in a world which is so saturated with COVID news that they've got to say something that shouts the loudest. And I think how damaging do you think that is, particularly for people living with HIV? I personally would say to people, I'm trusting my doctors to take the drugs that they tell me to keep my HIV in check.
Yeah.
To a person, they are all providing us with the same recommendation over our vaccine as well. So why should I not listen to them? Have you got anything that you could add to that?
Yeah, I mean, it's a huge issue, and vaccine doubters and vaccine denialists and anti-vaxxers, which I guess are the sort of agnostics and atheists of the vaccine world, respectively, that they've been around for a long time. And of course, social media, don't want to sound like some Luddite, I think social media has many benefits, but it also means things get shared and propagated. And we all know the issues of ending up in a bubble. My Twitter bubble means that I was convinced that Brexit wouldn't happen and Donald Trump wouldn't win the election because I'm followed by people who think like I do. So it's really challenging. And there's actually some really good World Health Organization guidance on how to deal with vaccine deniers. And the reality is there's no point engaging with the strong vaccine deniers because like any zealot, they're not going to change their minds. So what we can do is just try and get accurate information to the people who are uncertain, the people who don't know, the people who are worried by what they're reading. And so we've addressed that. So partly some of the HIV community organisations, so HIV iBase, which is a really good source of advice, have done a Q&A dealing with some of the vaccine myths. The British HIV Association has done some plain English guidance around vaccines. We've also basically stolen a video that the team at the Homerton HIV and Sexual Health Clinic made, just going through some common COVID vaccine myths. So that's on the BHIVA website. It's only a couple of minutes long. And I think the soundtrack's really cool, which probably means that I'm not, but it's, and that's how we deal with it. And it's not just an issue for HIV. So we know, for example, that people from Black communities are reporting higher rates of vaccine fear and vaccine resistance. And so NHS England are looking across the board about how do you get safe and effective vaccine messages to those groups of people. And of course, that also includes people living with HIV. So it's really challenging because it's hard to measure. At the moment, we're at that easy picking stage. There's so many people who want the vaccine still that they're just getting the vaccine. It's going to be months before we understand how many people haven't taken up the vaccine. And then it's a question about understanding why and trying to make sure the messages address their concerns in a way that's meaningful to them. But it's really hard to measure. So we would try and share the right information where we can.
And on that, with the right information, I had a conversation online with, she's a Bloomsbury patient, and she was really unsure about taking the vaccine and accepting her invitation to do so because of all of the things that she's heard. And her main argument was, and I've heard this several times, well, we haven't been able to cure HIV in 30 years, 40 years now, so how come this has happened so quickly?
Yeah, and it's all valid questions. I mean, ultimately, it's a very different virus, and despite all this concern about variants and the like, COVID doesn't hide from the immune system in quite the way that HIV does. And we know what apart from a very small group of people, that's getting too scientific, but most people with HIV don't develop protective antibodies. So your immune system is reacting to the virus, but it's not clearing it. And the type of antibodies that COVID produces are enough to protect you. So we know that if you've had COVID, you've got levels of protection for at least 6 months, similar to being vaccinated against getting COVID again. You don't have that with HIV. So COVID, you're trying to create something that you know is protective. With HIV, there's nothing that's protective at the moment. And so what do you stimulate? Because there isn't anything, and there is a lot of work going on. And actually, some of the work that's gone into HIV has helped guide the COVID vaccine efforts, and vice versa. There's loads of developments that have happened thanks to the sort of global effort with COVID that are going to help shape HIV research going forwards as well. So I think there'll be advantages for HIV care going forwards based on what COVID has taught us. I'm just looking at some more of these questions. I've had one jab, the controversial Astrazeneca. What's controversial is the way people have interpreted that data. The number of blood clots, this is the issue, that there's blood clots on AstraZeneca vaccine. There's no more blood clots. There's actually lower rate of blood clots in people who've had the vaccine than you'd expect in the general population. So you'd expect 1 or 2 people in every 1,000 to get a blood clot every year. And the rates of blood clots with this vaccine are not higher than that. It's bizarre. I don't understand. I think the world has gone slightly mad, and there's been other examples that I won't bore you with of people leaping on ineffective drugs or dismissing perfectly safe drugs based on completely alarmist reporting of vague scientific findings. So there's no good evidence, and the MHRA, who oversee the medicine safety in the UK, are really phenomenal, and they've got no concerns at the moment over the Oxford vaccine. So I don't think it's controversial. I think it's good. And I've had it. I was part of the trial last year. Now, a vaccine HIV positivity interaction in terms of medication. So this question, I hope we've addressed some of that in my waffle previously about the effectiveness. In terms of medication, this is actually quite a common inquiry we've had. The vaccine won't affect your HIV meds, and your HIV meds won't affect the vaccine. It's always an important thing to think of. There's no interaction at all between the two. So your vaccine will work. Sorry, Nathan.
So that doesn't matter what type of regimen you're on, what drugs you take, or which vaccine you get.
Absolutely zero. And interestingly, we've already had in the UK some GPs saying to people on PrEP, so people who are taking HIV medication to prevent HIV, that if they're on PrEP, they've got a suppressed immune system and they can't have the vaccine. I mean, it's absolute nonsense. It's not true, and there is no interaction at all. There's no animal products. They don't affect fertility. We can go through the 5G myths and Bill Gates and all those things. It's all utter. They don't change your DNA at all. And yeah, there's no reason to think your HIV medication. Question about, does it matter if you have the second dose of AstraZeneca after 4 weeks instead of 12? This is where there's good data. The AstraZeneca vaccine worked better with a 12-week gap than a 4-week gap. So actually delaying it is a good thing. We don't know the same for Pfizer. So Simon's asked a question about Pfizer. Is it safe to wait 12 weeks? It wasn't studied. It's being studied now. But in the Pfizer studies, they didn't look at that. In the Oxford study, they did. And people with a 12-week gap had a better response than people with a 4-week gap. And what reassures me in terms of if you're worried about the longer gap, I can't think of a single vaccine where a longer gap causes harm. So, for example, with hepatitis B, coming back to that again, if you have the doses very close together, which we do in some situations, your response is less good than if we space the doses out. Same for HPV, the wart virus vaccine. If you have the doses too close together, it's less effective. So based on what we know, a longer gap is probably better. We know that for certain for Oxford. We don't know that for certain for Pfizer yet, but I would wager that it'll either be the same or a better response if you wait. So, and then on that same note, is there any of the vaccines which is more effective? Sam, so no, there's no evidence that any of the vaccines are more effective at the moment. The one with a question mark over it is this Novavax vaccine, which we're not using in the UK yet. And there's some question around how effective that was in people with HIV in South Africa, but there's lots of complications there and we need to understand that more. So at the moment, no. And my advice to people is always to take whichever one you are offered, because the most important thing is to get a vaccine in when you can. So, and just as pointed out, the over 40s can book through the NHS UK website today. So there you go. You don't need to do that via GP. So there are links on that website and you can just book in directly. So it may well be we don't necessarily need to use our own clinic pathway.
I would assume if it's available on the NHS UK website, it's probably now down to the over 40s on the 119 vaccine helpline as well. Probably, yeah. To the internet, that'd be useful.
Yeah, no, absolutely. There's always a little bit of disjointedness across the country, and there have been issues with vaccine supplies. But I mean, on the whole, I think the NHS has done a quite remarkable job with the number of vaccines that have been rolled out so quickly. It's really quite amazing. So coming back, I had an AstraZeneca vaccine in January. You got high blood pressure. I'm scared of getting a second jab in April about blood clots. So honestly, there's no evidence that this is going to increase your risk of blood clots at the moment. There is always a background risk of blood clots, but there's no evidence that that is higher on this vaccine. Again, I do not understand what's driving some of this reporting. It's really quite phenomenal. It's dangerous. You know, it frightens people. And if you look at the risk of blood clots, it is not higher than it would be anyway. Asked about, will HIV positive people need a third vaccine? We don't know, and it's possible. It's possible that people with HIV will need a third vaccine, but we haven't got enough data at the moment. And just to emphasize, where we do have data, the vaccine does appear to be as protective in people with HIV at the moment. So we will learn that as we go along. And if it turns out that you do need a booster, you will get a booster. We'll get there, but at the moment, no good evidence, but that is a possibility if the response is not as strong. Let me just finish with the vaccine ones. Do we have to close HIV at the vaccine hub? No, my understanding is not, as long as you're in an eligible group. So the issue will be if you are self-referring. Can you self-refer into category 6? I don't know, but I think the fact that all over 40s are being offered the vaccine now, you shouldn't run into any problems. And my understanding is you don't need to disclose any specific medical conditions. But until I've actually got access to the link that you do the referral through, it's hard to say for certain. But again, we'll keep the website updated, and I'm sure we can get something up on the Bloomsbury Patient Network website as well. Is there a case for checking COVID antibodies after vaccination? Not at the moment. So as I said earlier, antibody measurement is only in trials and we don't know. So antibodies are only part of how vaccines work. They also stimulate something else called T cell responses. So being really basic about the immune system, you've got B cells making antibodies and you've got T cells doing other stuff. And we don't know the relative importance of the other stuff versus the antibodies. So it might be your antibody levels aren't the most important measure of how well the vaccine is going to work. And again, that's all work that's ongoing, and we're probably not going to know for several months. And again, it's possible we'll end up measuring antibodies routinely. It's possible we'll only measure antibodies in people at higher risk of low responses, and it's possible that will include people with HIV, but I can't say any more certainly than that at the moment. More vaccine stuff. So I'm due to have my first jab tomorrow. Can I specify to my GP the type of vaccine I'd like to have? I'm a bit nervous. No, I suspect you can ask your GP by all means. Some places are offering both, but my understanding is in general they'll have one batch of one or the other to use up. And I would just reassure you again that the Astrazeneca vaccine has been used in so many people. So actually we know much more about it. And I think that's what this blood clot story is about. It's just that so many people have had the vaccine that some people have had a blood clot, but they would have done anyway. There's no reason why that vaccine, when something causes a side effect, one of the first things we think about is something called biological plausibility. So is there any reason why that vaccine, that drug, that whatever it is, would cause that particular side effect? And there's no good reason why that vaccine would cause the issue. So I still think your safest bet is to get the vaccine that you're offered. Equally, if you're anxious, I understand why you might want to wait. So it might be worth just asking your GP if there's another option. But my advice to you would be to go ahead and have whichever vaccine you're offered. And it might be the Pfizer one anyway. And so we've got a couple of questions on being admitted to hospital and symptoms. So let's address those next, if that's all right. So more about the symptoms and how you felt when I had COVID. I don't know about my COVID experience. I thought I had the world's worst New Year's Eve hangover I've ever had. So I woke up on New Year's Day. I do like a drop of Campari, I'll be honest. And I had a very, very severe headache and really bad nausea. I felt really, really sick. And I felt really, really sick for 3 or 4 days. And I thought, I'm getting old. I've got a 4-day hangover. This is it. I'm on the downward slope of enjoying a glass or two of Campari. And I was doing regular tests as part of being on the vaccine trial. So I didn't do a test because I thought I had COVID. I did a test because I was doing weekly swabs at home because I was on the trial, and that's how I found out I had COVID. So those were my symptoms. But what's interesting, if you look at the symptom trackers, although we still talk about the cough, loss of taste and smell, fevers, there's a lot of people whose main symptoms are headache and nausea, tiredness, general aches, a whole constellation of symptoms. And it's a bit like, if one person gets flu, they'll have a very different experience to if another person gets flu. It's a bit similar with this. But yeah, certainly for me, it was the headache and the nausea. So I wouldn't dismiss any symptoms.
How long were you unwell for?
So I was unwell. Well, it's hard, isn't it? Because, now if I'm doing an online exercise class and I struggle with a burpee, I'm blaming COVID. So it's hard to say. But in terms of feeling really unwell, it's about 7 days for me. Probably 2 weeks before I've resolved completely.
My experience, and I guess I have the experience of somebody who is living with HIV and had COVID at the same time. I was ill for about 2.5 weeks. It was fairly severe. It started off with about 5 or 6 days of intense fever. So I had a very, very high temperature, night sweats, shivering, feeling really fluey, and just general malaise, which was pretty horrible. I have to say that horrible sensitive skin feeling where your bath feels like it's made of sandpaper. It's awful.
So it's really hard.
Then I had a bit of a rally for a couple of days, and I thought I was getting better. But then sort of the cough and the sore throat started, and I completely lost the sense of taste and smell. And it was before any of this had been reported on the news either, so I know it wasn't psychosomatic. I said to my husband, I said, I can't taste anything. He said, I've just heard that on the news. It's one of the brand new symptoms. This was exactly a year ago. And then then it was the crippling fatigue afterwards for almost 2 weeks before I felt back to my normal self. And I would get very, very breathless walking. I was still trying to do an hour's walking a day, which was all we could do at the very beginning of the first lockdown. And going up the very smallest little incline, I'd get very, very winded and be puffing and panting. If I was talking at the bottom of the hill, I'd have to stop halfway up, and it wouldn't be a very steep hill at all. I would say it was nowhere near as severe as my HIV seroconversion illness, which was pretty horrid, but it was much, much worse for me than a normal cold or flu. Horrid, but at no point frightening. I never thought I was going to need to be hospitalised.
And then that's a challenge. Do you feel fully recovered now?
Yeah, completely. So after, it's hard to know when you're fully better because that gradual climb back to full health, there's no sort of cut-off point. You just sort of, you don't wake up and go, oh, I'm perfectly well again. It's a more gradual thing than that. But I think I was ill for about 3 weeks in total, and since then, absolutely no long-term effects and nothing that makes me think that anything is lasting at all.
Good. I'm just smiling because I realised aiming that question at you, Nathan, not me. Like, no one gives a toss about what my COVID symptoms were. That's how self-centered I am. You see, this is the trouble. That's what happens when you live with a subservient husband and a cat. So next question is, if admitted to hospital with COVID-19, can I be confident I'll be able to continue my HIV meds while an inpatient? Will I have access to medics' experience in HIV treatment? So the answer is yes. I damn well hope so. We've actually made some guidance. So again, aware of the stresses of being admitted to hospital, but also the concerns, particularly for people with other conditions, including HIV, who want to continue their medications. We, as in British HIV Association, wrote some guidance very early on. And we co-wrote that with the Intensive Care Society, because we recognise that, if you get sick and you end up on intensive care doctors probably won't look at the British HIV Association website, however compelling we think it is, but they might look at the Intensive Care Society websites. We've got these co-badged guidelines. They were updated towards the end of last year, and that covers how to maintain medication, the importance of continuing it, drug interactions, and also seeking advice. So every hospital will have a pathway for getting advice from HIV specialists. So there's existing all across the country, existing systems for getting HIV specific advice. And actually the British HIV Association gets a few inquiries coming in as well. So I think we've got that pretty well covered, and there are really clear instructions about continuing medication if you end up in hospital. So that's one thing you won't need to worry about. Watermark and CD4 counts. We stopped measuring CD4 counts a while back. Is that going to change now with COVID so that a risk is minimized? So that's a good question, but at the moment, we don't really know exactly what CD4 is associated with a higher risk. So the data has been really mixed up. Some studies say CD4 count doesn't make a big difference. Others more recently are suggesting that it might, but where it might is if your CD4 count's below 350, and we've not stopped measuring your CD4 if it's below 350. And if you're not getting your CD4 checked and it's below 350, then just tell whoever's taking your blood that I said that you should get your CD4 count checked once a year. So we won't start. And actually, more to market in general, so the national guidance from BHIVA is that we should stop monitoring above 350. Some of the US guidelines say don't bother above 200. We actually tend to continue till it's above 500 because we recognise that we don't understand really what that 350 to 500 difference might make in terms of risk of other things. So actually, generally, you should still be having your CD4 count checked once a year until it's above 500 in Mortimer Market, which is more monitoring than some clinics do.
For somebody whose CD4 count has traditionally been above that threshold, who, if they're not getting monitored regularly, am I right in thinking that there would be other factors that might lead you to think that something was going wrong before you would start to need monitoring CD4?
Yeah, so the main one would be viral load. If your viral load goes up, we will check a CD. Now, if your viral load goes up to just a very low level and comes back down again, which we see sometimes, we call that a blip, then no, we wouldn't. If your viral load goes up and stays up, or if you've got unexplained symptoms, we often check a CD4 count. To be honest, it doesn't usually help that much. Or if we check what's called your full blood count once a year. So that's kind of a test of anemia, and it measures all of your white cells. CD4 are a type of white cell. But if your whole white cell count dropped down, then we would do a CD4 count then as well. So there are some scenarios when we would. Long COVID. Is there data on long COVID and HIV? No good data. So there's been a couple of studies saying, we measured long COVID in a tiny group of people with HIV at the end. That doesn't tell us anything. We don't know how common long COVID is in the general population, and just measuring long COVID. I mean, also I don't think we have properly agreed ways to measure long COVID. So the key thing is we need to come up with a standard definition, and we need to apply that to big groups of people, because there's no point just measuring long COVID in people with HIV. We need to understand, is that more or less common than the general population? Are there particular risk factors? And long COVID is going to be a huge issue for the NHS. In theory, there should be a specialised long COVID clinics in every part of the country. Some are already up and running. I think it's fair to say they're going to have a lot of work to do, but we're really trying to understand. And I think the real difficulty is the overlap between long COVID and the sort of post-traumatic stress of the COVID pandemic, that it's affected people's mental health so much. And because of that interplay, the overlapping symptoms of anxiety and depression and post-viral tiredness and stuff, it's really, really hard. So I think it's difficult to say at the moment. It will be a focus of research. And you know, as we learn more, if people with HIV are at higher risk of long COVID, we may end up running long COVID clinics for a couple of years in the HIV services. Who knows? But we need to gather that data to fully understand it. But yeah, it's the tip of the iceberg at the moment, I fear. Which vaccine are we being offered? Is it all right to wait if one is not ready to take the vaccine? Of course it's all right to wait, absolutely. You know, and vaccines aren't the be all and end all. You know, you still need to wash your hands, wear a mask, socially distance, all those kind of things. And one of the things that we must think about is what is the risk? Because, you know, a month or two ago, when 1 in 50 people in the population were estimated to be carrying COVID, going out in the park, there was a chance you'd bump into someone with COVID. As it goes down, then the risk is going to be less. So it's a very individual decision. Of course, it's fine to wait. I strongly believe that the benefits outweigh the risks and would encourage you to get one when you're offered. But if you don't feel ready to have one, or you want to wait to learn a bit more, you want to wait and see what the data on the Pfizer vaccine in people with HIV was and that kind of thing, I think of course it's okay to wait. But I think the important thing is, if you're choosing to wait, being sure that that's based on the right information. And chat to us, because one thing actually that's been reported by some of the community organisations is people not wanting to get the vaccine without speaking to their HIV clinic. So what we know from surveys across the country, so Positive Voices is one that Public Health England and some community groups did, and what we know is on average, not for everybody, but on average, people trust their HIV clinics more than they trust their GPs. And obviously that's something we try to encourage involvement with GPs, and there are some brilliant GPs, and some people would rather get their HIV care with their GPs these days, but on average people do trust their HIV clinics, and so we're really happy to answer questions and give the right advice. That's the key thing. Don't have it if you don't want to, but please make sure you're getting accurate advice and you're not making your decision based on inaccurate advice.
One thing that comes up quite a lot in discussion with people is about this subject is pregnancy and
Yes.
Potential pregnancy. Should somebody get the vaccine if they're planning to get pregnant later this year? Are there any problems? I know because there's no studies done so far in pregnant women getting the vaccine, but what about becoming pregnant afterwards? Is there any knowledge about that?
Not much, but again, you have to think about what evidence do we have about this specific vaccine, and what do we have to draw from our experience with other vaccines. So the flu vaccine, for example, is considered not just safe, strongly recommended in women who are pregnant. So if you're planning a pregnancy, I'd encourage you to get the vaccine. There's no evidence it affects your fertility, and there's no evidence. And again, you'll hear about this DNA type fears, and is it change your DNA and change your baby's DNA? No, it does not change your DNA, and it won't change your baby's DNA, so that's safe. If you're currently pregnant, we do encourage people to have a bit of a chat with their GP, but we encourage the COVID vaccine. So women who are pregnant are probably at higher risk of getting sick, because actually pregnancy suppresses your immune system slightly. And the Royal College of Obstetrics and Gynecology, who deal with all pregnancy-related safety issues, recommend the vaccine. So can I still take part in the blood study even though I've had a second jab? No, unfortunately. And this is a real challenge about how we get the message out there, because normally, you know, we've got posters in the clinics, and yeah, we can come on a bit closer to the end actually about a survey that we did, and the fact that loads of people didn't seem to receive it. So unfortunately not, but if you haven't had your vaccine yet, let us know. by any way, shape or means, stand outside the clinic and shout at us, because we should be able to get you on the study if you're happy to do that. Is the second dose of the vaccine the same as the first? So if it's the same brand, then yes. So if you had one Pfizer dose, and the second one will be the same as the first one. But there's been some reports of people getting different vaccines, so getting the Oxford, then the Pfizer, or vice versa. There are now studies looking at that, again, based on other infections. There's no reason why having one type of vaccine for your first dose and a different type for the second would cause any harm. At the moment, we're not encouraging that. If there's no other choice, then we would say go ahead and do it. But there's not much evidence to guide us at the moment. But I think in general, most people are being able to get the same second dose. The only exception would be, of course, if you were unlucky enough to get a reaction to the first dose, then you might be offered a different one for your second dose, just to minimize that risk. How to take part in the study you mentioned earlier. What's the best way to do this? I mean, I'd say email me. You're welcome to email me. My email address is freely accessible anywhere, but my inbox is a mess, and I'm worried if you email me, we won't get it. I don't know if any of our peer support workers are on the call about whether they could. Let me have a think about that. I'll come back to you before the end of the meeting.
We can put information up on the Bloomsbury Patient Network website, which is bloomsburynetwork.co.uk.
Yeah.
We'll get something up there in the next couple of days. There's a bit
Brilliant.
of a time to do that, but we'll do it as soon as we can. And
Yeah.
it may be that we can field those inquiries of people who are taking part and pass them on to Dr. Peppa.
No, that would be fabulous, because actually that would be great. And then we can pass emails on to the research team. Yeah, perhaps that would be the best way. So everyone check the website. It'll be updated by the end of the week. Nathan has promised. Why some people get a second vaccine booked and others have to wait for a text, that's just going to depend on the local systems. So everyone's handling things slightly differently. So yeah, it just depends where you're getting it. I've been sent a shielding letter, but my health's not changed since last year. Do you advise ignoring it? Oh, this is the $1 million question. My goodness. It's hard for me to talk about this without swearing. It's been frustrating, to put it mildly. We had a meeting with the Department of Health and NHS Digital at the end of last week. So what's happened? Firstly, last year, a lot of people with HIV got shielding texts and shielding letters, even though the government didn't think they were higher risk. And we've never really had a decent explanation. It was all down to coding. So some people with HIV, somewhere along the line, have had an immune suppressed code put on their records somewhere, and that's what generated that round of communications, which was very frustrating. They're very apologetic. And then it happened again. I think we were prepared. This time round, suddenly, with no warning whatsoever, an additional 1.7 million people in England and 800,000 in London alone got put onto the shielding list for the first time. So these are the people considered at highest risk, who should definitely stay at home, who get the vaccine sooner, eligible for support with shopping and all that stuff. And the reason they've been put on the list is because the team at the University of Oxford have come up with this new risk calculator called COVID. Now, some of you may have been in clinic if you are 40 or older and had your Q risk 3 calculated. So don't know if you sat there while one of us has been tapping your numbers and details into a calculator. It tells us what your risk of heart disease is estimated to be. This is the same thing, but for COVID. So they tap in age, other illnesses, postcode, all sorts of things, and they come up with a risk. So, for example, the fact that you were undetectable and not on the shielding list last year, even if nothing's changed for you, they have done more work on the data. It may be that it might just be that you live in an area where the risk of COVID is higher because it's an area that on average has denser housing. It may be that I don't know your medical history, but maybe you've got high blood pressure or diabetes. It might be based on your ethnic group. So we know Black people have a higher risk of dying from COVID than white people, for example. We don't truly understand, but the chances are that you may, based on this calculator, be at a higher risk genuinely, or it may be that it's based on inaccurate data. So for example, if your GP record doesn't have your weight in it, they will assume that you are obese rather than not obese, because they don't want to miss people. If your ethnic group isn't included, they won't assume you're white, because that puts your risk lower. They'll assume you are black, because they're trying to safety net and not underestimate anyone's risk. Now, to complicate it further, and tell me to shut up if I'm waffling too much.
That's fascinating.
The way they decide if you're on this shielding list or not, if you're one of these 1.7 million people, this is affecting loads of people, not just people with HIV. You go on that list if your risk is 10 times higher than someone else of the same age. So if you are 27, but you happen to be black, and you happen to live in a postcode where the risk is higher, your risk might be 10 times higher than it would if you were white and living in a different postcode. Your risk could still be very low. So coming back to that point I was making earlier, if your risk is doubled and it goes from 1 in 10,000 to 1 in 5,000, it may be that your risk as a 27-year-old is 1 in 20,000 and 10 times is 1 in 2,000. That's still a low risk. We wouldn't consider that a high risk, but you go onto the high risk group because it's 10 times higher, if that makes sense. So just because, again, it's all down to relative versus absolute risk. We ask them this, why are you basing it on relative risk if the actual risk is still very low? And it's all to do with trying to capture as many people as possible. They don't want to miss people out. They don't want to falsely reassure anyone. So because of that, the risk is that they are over anxious about people, if this is all. So I'm starting to waffle now. But the key thing is you don't have to follow the advice. So what I would do in that situation, if you're on the shielding list, you don't really think that you should be, have a chat to your GP or have a chat to us. I don't know if we've got the access through yet, but I've applied for permission for our clinic to be able to do the calculation with you in clinic. So we can check your actual risk and we can say, yes, okay, your risk might be 10 times higher, but it's still only 1 in 20,000. Therefore, we reassure you, for example. Does that make sense? Sorry, I do start waffling.
That's really, really interesting, because obviously this is something that affects lots of different people and can confuse lots of people as a result of the sort of conflicting bits of information that they're receiving. It's always good to, this is the problem with half bits of information, isn't it? This is the trouble with that's on its own a piece of information can sound really, really frightening and dangerous. Yep. When you look at it in the wider context, it may not be quite so severe at all.
Yeah, and it's because one of the areas of health where there's been a lot of miscommunication is hormone replacement therapy, or HRT, for women around menopause, and it's again when the Daily Mail says HRT doubles your risk of breast cancer. Actually, what's important is they've done some really good leaflets showing 100 people, and if half a person was going to get breast cancer off HRT, it might only be 3/4 of a person out of that 1,000 getting it. No, those aren't the actual figures. I'm just making that up. But putting it into a context that people can understand. Your risk might be doubled, but it's still no greater than the risk of being hit by a bus when you step outside your front door. And putting it into just things that mean stuff to people, because I think sometimes numbers just don't. But yeah, if you're worried, have a chat to your GP, or hopefully by the end of this week, us, and we can actually calculate your risk for you. Actually, you can go online and do it yourself. They tell you you're not meant to, but there's nothing to stop you Googling Q COVID and putting your own information into the calculator and working it out yourself.
That's fascinating. Thank you.
So we've got another question. Is there any evidence people with HIV have a worse response or worse side effects to the vaccine? So I don't know if we discussed that at the beginning. So in a nutshell, no evidence of more side effects, possibly less response, but no evidence for that at the moment. That's being studied. But at the moment, the advice is just get the vaccine. If I'm abroad and I'm offered to have the vaccine in another European country, can I have it? Yes. Would the UK accept the certificate? I don't see why not. I don't know, but if you've had the vaccine and you tell someone you've had the vaccine, then I think that would be accepted. I mean, if you've got evidence of having the vaccine is the best thing. It's always good to keep a record of when you had it and what type you had. So I don't see why there would be any more issue than that. Hello, some people I know have felt rough for a day or two after the first vaccination. Is that side effect less likely after the second vaccine, or would it be the same for people with HIV? So no evidence that people with HIV would get more side effects from the vaccine. And if you've had some side effects for the first, generally, it seems that you probably get those same side effects, maybe a bit more severe with the second. But they're usually pretty manageable.
The way I look at it is that if you're getting side effects, it means two things. It means one, the vaccine's doing its job, and two, so is your immune system. So that's win-win, right?
Yeah. No, and I think it's exactly. But equally, if you don't get side effects, doesn't mean it's not working.
Necessarily about
we're all individuals, and Mike had no side effects whatsoever. Good. I haven't had the vaccine yet, but I'm with another clinic. Can I still measure antibodies with you? Yes, I don't see why not. The whole point of research is it's accessible to everybody. So again, keep an eye on the website, get in touch with us, and we'll find a way. You need to register with the clinic. That doesn't mean you transfer to the clinic. So yes, that'll be absolutely fine. But you're with another clinic, come to ours. Are there any disadvantages of being on the shielding list? Good question. No, not really, because none of this is enforced. So no one's going to, there's no police officer outside your house stopping you leaving. So the advantages are what I mentioned. You get the vaccine sooner, you get support if you need it at home. As lockdown restrictions ease, if you're on the shielding list, you may still be being advised to shield when the rest of us are allowed to stand in a field with one person, but you don't have to follow that advice. It's advisory, it's not mandatory, it's not obligatory, it's not law. You can do whatever you feel safe to do. So I don't think there are disadvantages to being on the shielding list. One thing though, if you were on the shielding list last year and you didn't think that was accurate, so let's say you were a patient at the Bloomsbury Clinic and you came to us and said, I've been told to shield, I'm well, my HIV is well controlled, and we said, well, you don't need to be on it. If you wanted us to, we wrote to NHS Digital and took you off the list. If you got taken off the list last year, you won't have been considered to go back on the list this year. So there is a risk. There are some people who are at genuinely higher risk based on the new information we've got that won't have had that advice. So we've put that on the BHIVA website. And if you're somebody who got shielding advice last year, I would strongly encourage you to get your GP or us to recheck your risk now in case you are at genuinely higher risk. And it is frustrating because it feels like mixed messages. We told you one thing last year, we told you something different this year. It's because we're always learning, and it's natural that as we learn more about what's happening, some of our advice is going to change. But I can promise you, what the advice we're giving you now is always based on the best evidence and your best interests at the time. And if it evolves, that's because new information has become available.
My own personal way of dealing with stuff that I read online is always check the date of the article, always check to see if it is the most up-to-date version, or if it's something that sounds plausible but maybe it was 6 months ago. In such an ever-evolving environment like the COVID-19 crisis, things change so quickly. So I tend to try and find things that are only a couple of weeks old at the latest.
No, absolutely. We've got a question here. Been advised to shield until 31st of March. How do I know if I have to stay longer? You'll be told. So keep an eye on the gov.uk website is the best advice I can give. They do keep that very up to date. If it's extended past that, I hope you'll get another communication explaining that. But if not, and again, if you're really not certain, give the clinic a call because we can help you find out.
I think one of the good things, Laura, is that the policy was made that all people living with HIV would be placed into category 6 priority for the vaccine. That was great. Is there any information about different aspects of living with HIV that might put some people more at risk and some people not really at a higher risk, but were included anyway to keep things simple?
Yeah, good question. So if you have no other risk factors for severe COVID, then you don't seem to be at higher risk. So if you are younger with no conditions like diabetes, asthma, high blood pressure, other things that increase your risk, then your risk appears to be no higher. So one of the studies from the UK looking at this very issue showed that for people without other comorbidities, so other illnesses in addition to HIV, their risk of dying from COVID was not higher than the general population. So if you're in that group, you don't need to worry. For everyone else, it's
on its own, isn't it? So just HIV literally on its own isn't necessary.
Although if you've got HIV only and you're 80, good going. But you will be at the same risk as someone else who's 80. So your risk is going to be higher. It's just not going to be higher than it would be anyway. if that makes sense. So yeah, HIV only and no other risk factors, then you don't need to worry. Do you still send out appointments for bloods, etc.? I can't remember where I last gave bloods at Bloomsbury. It's a good question, Anthony. So yes, we do. So obviously what we've been doing has been very subject to what the restrictions are. So it was on my list of things to talk about, actually, of the impact of COVID on HIV services. So I think it's fair to say HIV services have been much less effective than some other outpatient services in the NHS. And again, I think we'll only start understanding those over the months and years as we come out from this. So we've always maintained emergency capacity. So every single day of the week, we have emergency appointments available. We do run some limited face-to-face appointments with consultants. Most of the stuff's being done by phone. We call it virtual consultations, but as you know, it's me, usually in this room here, my dining room at home, doing clinics. So we have been still been doing some blood monitoring. So hopefully most of you would have been contacted if you hadn't had bloods within the previous 6 months. We tried to get everybody back between kind of August and December last year, because we recognised there was going to be another lockdown likely. We wanted to get everyone back in to get some tests. So I think we managed to do tests on something like 4,000 people out of the 5,700 in the 4,000 people out of the 4,700 in the service. So most people came back. At the moment, it's all a bit hodgepodge and a bit up in the air. So we are bringing people back for appointments. Generally, they're booked by us when we think they're needed. They're not necessarily tied in with your appointments. And the previous Zesty system that some of you may have used, where you could book your appointment online, we no longer have a contract with Zesty. So we're trying to work out what's the best way of sorting this all out going forwards. So the answer is we will go back to routine blood reminders at some point in the next couple of months, and all will be clearer. But again, keep an eye on the website. And I think one of the things we're going to try and do is better link up the Bloomsbury Patient Network website with the kind of official NHS website. Not the Bloomsbury Patient Network's not official, but you know what I mean, it's all NHS website and the Bloomsbury one. So there's a bit more cross-linking between the two. But ultimately, if you go onto our website, there's all the numbers that you need to call. And at the moment, the only way to really get through to us, so we've got an emergency mobile phone number, which is freely available on the website. So if you've got an emergency, you want to speak to a doctor today, you can phone that number in normal working hours. And if we can't answer it, we'll get back to you. Then for non-emergencies, we have this number that goes through to the secretarial team. We're just in the process, high time really, considering the fact that people have been asking intermittently, is to set up an email address as well. So there'll be an email account. And now I know a lot of our staff give out their emails anyway. But the trouble with staff, especially if it's me, is you may have my email address, but you may well not get a reply sometimes because my inbox just gets a bit crazy sometimes. So it's not very reliable. I always say never email about an emergency, but we'll have a general email address that will be checked every day by a member of the team who can then give you the right advice. So there will be another way to get in touch with us as well. So if it may well be that we'll be asking people to email in to book blood appointments. Hopefully, eventually, we're going to have a proper patient portal where you can log on, book your own appointments with telephone or face-to-face with the person you want to see. You'll be able to book your blood appointments. You'll be able to view your results. You'll be able to view your medication list. I mean, that's the goal. But at the moment, the electronic patient record system we use can't do all of that. So we'll get there. Oh, it's a really silly question. Nothing's a silly question. What's the website address you guys have been talking about? As I never use a website, and I clearly should. Thank you. And you've been amazing. Is that to me or Nathan?
It may be that it's the Bloomsbury Network website you're talking about. At the moment, it's in a little bit of disarray. There's been lots of upheaval and sort of personnel changes over the last 12 months, and we are working as hard as we can to try and resolve that and get everything back up and running, because we want the Bloomsbury Network website to be a real one-stop hub to link you to lots of other places. I would say for all information about anything that Laura's been talking about tonight, definitely the BHIVA website, the British HIV Association website. Yeah. Is such a repository for the most up-to-date, most specific knowledge, not only to HIV, but also COVID and HIV as well. But we will be linking to that. But our website is just bloomsburynetwork.co.uk, and BHIVA is just BHIVA.org, isn't it?
It is. So yeah, www.biva.org. And I don't know if I can paste, there's the clinic website as well. Can I paste that anywhere?
And you can put it into the chat, Laura. For anyone
Where's
who,
the chat? Oh yes, so we go into chat.
make sure you select it to attendees and panelists.
So let me do that now. Here we go. So to all panelists and attendees. So this is the link that takes you directly to the Bloomsbury Clinic website. Or if you Google CNWL HIV, that will come up too. But that's the link there. And here's, I'll put the BHIVA one in as well. I know that one off by heart. There's the BHIVA one.
Great. That's fantastic. And so just finally then, what do you see is the future? What are the next steps with all of this? And is there any sort of indication on ongoing links between COVID and HIV, or anything we need to be aware of or watch out for going forward?
So no, it's a learning curve. So I think my best advice is to if you've not looked at these websites before, please do. If you think they're crap, tell us, because the information is there for people who use the service and for people who don't. I think we're very lucky, actually. We've got a really good website team within our trust who can make changes really, really quickly. There's some good information on there. But we've not done enough to test this. Have we done a focus group on the website updates? No, we haven't, because the issue with COVID is we've done so much so quickly, again, just to try and keep people safe and keep them in care. But we've done an awful lot of things that we wouldn't have rushed into. So the key thing, in general, we will keep you updated. And one of the great things about being a patient at the Bloomsbury Clinic is that we've got an amazing research department within our building. And they do some, like, when you look at some of the studies that are done in sexual health and HIV, it's a really amazing unit. And so some of the work I've mentioned around measuring antibody levels and the like, that's being done in our department effectively, which is amazing. So we'll keep you updated. We'll keep both the websites updated. Again, have a look at the BHIVA website, because we'll continue to update that as well. But thinking about our service more generally, it's about how do we use some of the benefits? Because I think one thing we've learned from our patient survey, I'll come back to that, from our patient survey, there are a lot of people who'd never had a phone consultation before. So we've promoted virtual clinics in the past, perhaps not strongly enough. And people have kind of been, oh, well, I quite like popping in. It's quite nice seeing you. And one bit of the feedback was, actually, now I've experienced a phone consultation, it was great. It was more convenient. I was at home. I'd like to do that again. So we need to move out of this, offering people a range of options for their care that suits them best. So the patient survey I mentioned, and one thing that would be interesting to get all of your views on, is we were thinking maybe for the next forum, my colleague Stuart organised a patient survey where we sent out a link about people's experience of the clinic during COVID. Now, one thing is it seems that not everybody received the survey. So in theory, everyone who'd given us their mobile number and given us consent to use that mobile number should have got a link to a SurveyMonkey online tool to fill in this questionnaire. Now, anecdotally, it seems that quite a few people didn't get that. So I think one thing we need to understand through the network is, what's the best way to seek your views? We will be doing some focus groups, and we'll be engaging with the network to do that, because we've got a clean slate in a way, and we can redesign the service. And it may be that we see people, we do more phone consultations with a slightly more hands-off approach, but then more intensive visits every 1 or 2 or 3 years, depending on your own risks and your own preferences. And there's so much we can do. There's so many opportunities to sort of save time with some elements of your care, so we can focus on things that are important for you. So we will be involving you all going forwards. We've got this survey. We'll find out, how we get that survey to more of you if you didn't receive it. And we've also been doing some in-depth staff surveys as well, to try and pull from everyone's experiences throughout all of this to make the service even more amazing going forwards.
That's fantastic, Laura. It really, it's been such an extraordinary year. I'm aware that some people will have read information that said that we were finishing at 7:30. I apologise for that. We thought we were finishing at 8 o'clock. So we'll probably use now as a bit of a wrap-up time, and then I'll get that poll open. So if anyone's in a hurry to head off, so if you could just stay a few more minutes, I'll get the feedback poll on your screens very shortly. But Laura, this has been really, really fascinating. Thank you so much for being part of this.
Not at all.
Get it from a voice we can trust and an information source that isn't the social media hysteria, which is often so difficult to ignore and so in your face all the time. Thank you for that. It's been wonderful.
No, it's an absolute honour, and you know we're always here, and you know as a service we never get it right 100% of the time, and you know you know it's been really tough for the service as well. We've had a lot of redeployed staff, a lot of uncertainty, a lot of people off sick and shielding. The NHS, you know, the morale of NHS workers has been, you know, I don't need to tell you, it's been really difficult. But the most important thing is if we're not getting it right is tell us, you know, be patient with us, be kind to us, but we are ultimately here to keep you well. And if in any way we're not doing that, or there's things we're not getting right, or there's information we're not sharing in the right way, please tell us. And again, with this reinvigoration and refreshing of the Bloomsbury Patient Network, we can use that. And we know it's not easy necessarily to sort of speak to your doctor or your nurse face to face and share things that you're not happy about. So you can always use the network as a way to sort of give us suggestions. You know, some people don't feel comfortable to sort of comment in person. So just give the feedback to the network and they can feed back to us.
That's one of our main functions as well. I very firmly think that our unofficial strapline is it's your network, your voice counts. So please do use the service as much as you can. Use the website. We are Laura. I can let you go now. Thank you very much. I know you're a very busy lady. Thank you so much for this, and well, hopefully have you on another forum again soon.
Perfect. Thank you very much, everybody, and stay safe and stay sane.
But for everybody else, thank you. And as we were saying just then, it's so important to us that we get a chance to give you an opportunity to speak through us. We can be a sort of clinic liaison or an intermediary if you don't feel that there's things that you can talk to the clinic, and if there's things that you want to talk to us about as peers as well. There are the peer support workers working at the clinic who are paid and trained to do that, but we are also, we're in the same boat. If you're a Bloomsbury patient, we in the Bloomsbury Patient Network are patients as well, so it may be useful to use as a sounding board and know that we're all in it together. With that in mind, I'm going to activate this poll now. It should be popping up on your screens there. So hopefully you can see that now. Thank you so much for coming along to this. We've got a very exciting projected program of events coming up over the next 6 to 12 months, which we'll be putting more information up on our website. If you are a Bloomsbury patient and you're not signed up to our website yet to receive the newsletter, then you can go to bloomsburynetwork.co.uk, scroll down to the bottom of the page and you can add your email address there. We have one of the biggest security experts looking after our website for us, so you can be sure that your data will be very safe and very protected. It's just a really good way of, if we can expand the membership of the network, then what we can do is we can be a more representative voice on your behalf, and that is all that we care about trying to get sorted. Thank you so much for being part of it tonight. I'm going to put back up the holding screen and I shall leave the poll open there, so once you're done, feel free to disconnect, and I look forward to seeing you and welcoming you to the next few virtual events, and in the near future, let's hope we can start doing some in-person events as well, if those are the kind of thing that you prefer. Thank you very much for your time tonight, and goodbye.